Welcome to the first webinar in our 4-part series, Play Like a Girl, Health and Wellness in Girls Sports. Today, we are so excited to bring you our first webinar, You Can Save a Life, the signs, symptoms, and what to do about eating disorders. This is such an important topic for so many people. So we are going to dive right in. Next slide, please. Here's just some quick housekeeping. We will have a Q&A session after the presenters have finished. Throughout the presentation, feel free to use the chat feature. We want you to discuss in the chat. And we would love to hear your questions. We will be using questions from the chat. Any questions that we do not get to, I would encourage you to submit those questions for our 4th webinar, which will be a panel discussion. We'll bring back some of our previous speakers to speak in a panel to answer your questions. So anything we don't get to today, please submit for that webinar. And we'll be putting the links for that in the chat and in the email that will follow this webinar. Recordings along with a whole bunch of resources are going to be sent to you after this webinar. So please look out for that. And please complete the feedback survey after the meeting. This is how we get ideas for future meetings and how we improve. So please fill out the survey. And of course, thank you for participating. We are pleased that you are here. And we are so honored today to be joined by 2 amazing speakers who we're going to be introducing here in a moment. Next slide, please. This is our standard disclaimer for HHS. Next slide. And at this point, I would like to introduce my colleague, Sarah Schildecker, to give a quick overview of what we do here in OASH Region 6 in our office. So Sarah, please take it away.
Thank you, Monica. My name is Sarah Schildecker, and I'm the Senior Public Health Advisor in the Office of the Assistant Secretary for Health Region 6, which is located in Dallas, Texas. Region 6 covers the 5 states of Arkansas, Louisiana, New Mexico, Oklahoma, and Texas, as well as 68 federally recognized tribes. And as Monica said, I also sincerely thank you for joining us to speak about this under-discussed yet incredibly important health topic that spans both the mental and the physical health of our youth. Next slide, please. The Office of the Assistant Secretary for Health is responsible for overseeing the Department of Health and Human Services, key public health offices and programs, as well as advancing health priorities and policies nationwide. Next slide. There are 10 regional health offices that are headed by a regional health administrator and a team of 3 staff, senior public health advisor, a regional minority health analyst, and a regional women's health analyst. You'll see Region 6 at the bottom of the screen, with the picture of Captain Mayron Masudi, who's our regional health administrator and could not be with us today due to travel conflicts. The Office of Regional Health Operations provides regional coordination and support for key public health programs and policies and priorities. It does so by convening partners, establishing networks, and hosting events such as the one you're attending today. We advance health outcomes by focusing on health disparities and ensuring we apply a health equity lens to all of our efforts. Next slide. There are 4 major health priorities here in Region 6. First is access to care, which includes chronic disease prevention and treatment, nutrition and hunger, community health worker sustainability, and overall preventive health. The second is maternal health, which is not only morbidity and mortality, otherwise known as disease and death, but also general well-being. We also have climate change, which focuses on extreme weather events and natural disasters that have been increasing over time, but it also focuses on environmental exposures to hazardous materials. And finally, we have harm reduction, and we take a syndemic approach to harm reduction. And what this means for us is just looking at the intersection of substance use disorder, mental health, and infectious diseases that are associated with drug use, such as HIV, hepatitis C, and other sexually transmitted infections. So at this time, I'd like to pass it back to Lieutenant Monica Geiger to introduce our speakers. Thank you.
Thank you so much for that. I really appreciate it. And I just want to emphasize why we're here today. Coaches are in a critical position to influence young girls. We know that sometimes girls might listen to their coaches even more than they listen to their parents. And they are in a position to instill habits that promote physical and mental health and well-being. They are also in a position to facilitate a referral to care and other services should the need arise. So this series seeks to promote a culture of health within the sporting community and instill in girls a healthy lifestyle, both physically and mentally, starting from a young age, in the hopes that these habits will prevent the onset of chronic disease and associated complications. So each webinar in our series will last 1 hour and will cover topics including childhood obesity, eating disorders, sports nutrition, and why health and wellness are critical to health, well-being, and the performance of our young athletes. So today, we are happy to be talking about eating disorders in our first part of the series here. And I would like to acknowledge Dr. Bridget King with the Lady Panthers Basketball Association, who has been a very close partner and ally in this effort. Next slide, please. We are working with the Office on Women's Health to promote National Eating Disorders Awareness Week, which is occurring next week. So that's going to take place from February 26th to March 3rd. So please check out the resources, which will be in your email from the Office on Women's Health. And I wanted to mention that eating disorders are the second deadliest mental health illness behind opioid use disorder. Let me say that again. Eating disorders are the second deadliest mental health illness. And this is why it's such an important topic. OWH is promoting resources and information as well as events during National Eating Disorders Awareness Week. And that is one of the resources that I'll be sending you. Next slide, please. And please complete our evaluation and register for the next webinars. Next slide, please. So now it is my distinct honor and pleasure to introduce to you our speakers. Our first speaker is going to be Sarah Brisco from Ozark's Unlimited Resource Educational Services Cooperative, Community Health Promotion. She's a community health promotion specialist from the Arkansas Department of Health. Next slide. Following her presentation, we'll hear from Dr. Tiffany M. Stewart. And we're so excited to have her here. She's a Dudley and Beverly Coates Endowed Professor and the Director of Behavioral Technology of the Behavioral Technology Laboratory, Health, Performance, and Resilience. And if you haven't already done so, please watch her TED Talk. It's really amazing, where she talks more about this topic. And with that being said, without further ado, I'd like to turn it over to Ms. Sarah Brisco to kick us off.
Thank you, Monica. And I will share my screen. So good afternoon. It's very nice to be with you today. I'm honored to speak to you today about eating disorders. I would like to begin by telling you a little bit about my story. This is my identical twin, Mary. She's actually joining us today from New Mexico. Health and weight were always talked about in our home, growing up so much so that I began long distance running as a young girl and did this all through school and into college. In my freshman and sophomore year of college, I noticed my body changing. At this time, I weighed around 125 pounds. I'll never forget one particular weekend, actually a very life-changing weekend. We went home and I was told that, I'm sorry, I don't usually share this, but it takes me a second to get through this. But I went home one weekend and I was at a local store and someone asked me if I was Mary or Sarah. We got that quite often. A man was standing nearby and said, "She's the fat one, so it must not be Mary." Well, that planted the first idea in my mind that maybe I was overweight. Then it wasn't too much longer that I went home and my grandfather said, "Now, don't you go getting fat on us." Well, at this point, I made up my mind that I would never, ever feel this way again. I started to binge and purge, and within 3 months, I lost down to 99 pounds. And it has been a struggle to this day. I tell you this so we can know as educators how to recognize and help those struggling with an eating disorder. I want you to think for just a moment on what the absolute most important thing is to you. And if you lost this thing, how bad would it make you feel? So for me, I would say my family. So that tells me that they are very important to me. Suppose someone said they were going to take this most important thing or person away from you. We would put up a fight to keep it. This is how those with eating disorders feel. Weight, shape, and appearance are the very most important thing to them. So who you are as a person is determined by what you look like. This is a picture that was created by a lady named Mary, who at one point in her life was living in a large body. She worked really hard to lose lots of weight, and she managed to do so. She found it difficult to get the help she needed because she looked healthy. This picture represents that all of these people suffer from a serious life-threatening eating disorder. You will notice the person on the left represents someone living in a larger body. And then you have someone that has a frail appearance. And then there in the middle, you will notice someone that appears to have a healthy appearance. And then an older person. And finally, on the far right, a male. So what are eating disorders? They are real life-threatening illnesses with potentially fatal consequences. They do involve extreme emotions, attitudes, and behaviors surrounding weight, food, and size, and they're caused by a range of factors. As many as 30 million Americans will struggle with an eating disorder at some point in their life. There is a false belief that most people with eating disorders are privileged young white women. While eating disorders do affect young women, they also affect men, transgender people, people of color, older people, young people, and people with disabilities, and people from every walk of life. Eating disorders are very complex. Eating disorders arise from a combination of factors. While they may begin with preoccupations with food and weight, they are most often about much more than food. Biological factors include family history, a history of dieting, and genetic predisposition. Research shows that adolescent girls that diet are 18 times more likely to develop an eating disorder within 6 months. This becomes a 1 in 5 chance if the diets last over 12 months. Research shows if we are genetically prone to eating disorders and dieting is involved, the only way to overcome an eating disorder is to regain weight to a healthy body weight. So there are a few factors that go into this. So psychological factors could include low self-esteem. They may feel feelings of inadequacy. And then, of course, depression, anxiety, fear, and loneliness can go along with that as well. A few of the social factors, of course, are cultural norms that overvalue appearance, body dissatisfaction, a drive for perceived ideal body type, historical trauma, and then weight stigma and bullying. I'm going to go over 9 truths about eating disorders. Many people with eating disorders look healthy, yet they may be extremely ill. However, families are not to blame, and they can be the patient and provider's best allies in treatment. An eating disorder diagnosis is a health crisis that disrupts personal and family functioning. Eating disorders are not choices, but they are serious biologically influenced illnesses. And like I said earlier, they do affect people of all genders, ages, races, body shapes, and weights. Eating disorders carry an increased risk for both suicide and medical complications. Genes and environment play important roles in the development of eating disorders. However, genes alone do not predict who will develop an eating disorder, but full recovery is always possible with early detection and intervention. So just a few common warning signs: weight loss, dieting, control of food, food rituals, social withdrawal, frequent dieting and body checking, and extreme mood swings. Noticeable weight changes, like I said, gastrointestinal complaints, dizziness, difficulty concentrating, issues with dental, skin, hair, and nail health are also some other common warning signs. The above list describes some of the general warning signs of an eating disorder. Detecting an eating disorder can be tricky, and a big indicator can be noticeable change in a person's attitude toward food in their body. While there are more specific signs depending on diagnosis, not everyone fits neatly into these categories. All eating concerns deserve immediate attention. Anorexia is likely the best known eating disorder, and it's primarily characterized by self-starvation. And you'll notice the symptoms here on the slide. The primary symptoms include inadequate food intake, a disturbance in the experience of body weight or shape, intense fear of weight gain, and an inability to appreciate the severity of the situation. Bulimia is characterized by binge eating and behaviors to reverse the binge, such as self-induced vomiting and an attempt to undo the effects of binge eating. Like I mentioned, bulimia is primarily characterized by binge eating and any behaviors that are meant to reverse the effects of the binge, such as vomiting, laxative abuse, and excessive exercise. Concern with body weight and shape and feeling out of control during the binges are also symptoms. Most people struggling with bulimia appear to be of an average weight. It's important to keep in mind that you cannot tell if someone is struggling with an eating disorder based on weight alone. Binge eating disorder is characterized by sessions of binge eating. It differs from bulimia in that there is no behavior like purging. An important component of BED is that the person feels out of control during the binge and distressed following it. BED is the most common eating disorder in the United States, and it's often misunderstood as just overeating. It's important to know that BED is not a choice, and it has a significant psychological impact on the person suffering. And just a few symptoms you see here on this slide, but the most important one here I will mention is the feelings of strong shame or guilt regarding the binge. And then we have avoidant restrictive food intake disorder, and is an eating disorder that can appear as an extremely picky eater. Those struggling may demonstrate a lack of interest in food and experience unexplained body discomfort. The limited range of acceptable foods narrows over time. Many of those who struggle with eating disorders have co-occurring conditions such as anxiety, substance abuse, obsessive compulsive disorder, depression, or post-traumatic stress disorder. All conditions should be identified and treated by someone with expertise in both eating disorders and any co-occurring conditions. Up to 50% of individuals with eating disorders abused alcohol or illicit drugs, a rate 5 times higher than the general population. Depression and other mood disorders co-occur with eating disorders quite frequently. Up to 69% of patients with anorexia and 33% of patients with bulimia have coexisting diagnosis of obsessive compulsive disorder. Only a treatment professional can determine which level of care is appropriate for someone just beginning treatment. Determining the appropriate level of care takes into consideration the patient's medical and psychological states. So, how do we help? We learn as much as we can about eating disorders. Be honest, vocal our concerns, but always be caring and firm, and suggest help for them from a physician or a therapist, and always be a good role model. But what we don't do is we don't place shame, blame, or guilt. We don't make rules or promises that we cannot uphold, and we don't give simple solutions. We don't invalidate their experience or try to convince. We don't give advice about weight, exercise, or appearance. And we never ignore or avoid the situation until it is severe or life-threatening. When eating disorders come up, whether you're giving a presentation or just chatting with a friend, keep in mind a few guidelines to make sure you're discussing them responsibly. Don't emphasize numbers or tips, such as he took as many as X laxatives a day, can turn a well-intentioned story into a how-to guide. Watch out for the appearance ideal, such as a societal or cultural focus on having a certain body type. Eating disorders are mental illnesses and they are not glamorous. And emphasize the seriousness of eating disorders without portraying them as hopeless. Recovery can be a long, hard process, but it's always worth it. Always encourage people to seek help for themselves or their loved ones. And don't focus on graphic images or descriptions of the body at its unhealthiest point, such as at her lowest weight, she was only X pounds, could be interpreted as a challenge, such as she's X pounds and she's still alive. I should lose more weight. Overemphasizing the physical aspects of eating disorders may also overshadow the fact that they are mental illnesses. This concludes my presentation, and I'm happy to answer any questions.
Thank you so much, Sarah. That was a really powerful story and presentation. So thank you so much for that. I really appreciate it. And now I'd like to turn the floor over to Dr. Tiffany Stewart for her presentation, and then we'll have a Q&A session after that's concluded. Thank you. Please, you have the floor, Dr. Stewart.
So thank you for having me today. I am truly honored to speak as a part of this series and be a part of this group. And Sarah, I thank you for your presentation. I'll be making points that dovetail nicely with some of the things you said. And some of the things you said were truly important and missed points in many presentations that are given on this topic. So thank you so much for that. I'm coming to you from Louisiana, from Pennington Biomedical Research Center, and we are a campus of Louisiana State University. And we are a big D1 sports school, as you know, so we are consultants for our LSU athletes and do a lot of work with them on this topic. I was also a clinician for many years, caring for women and athletes in hospital programs for severe eating disorders. So this is kind of a dovetail of our blend of science and clinical work. We have a 25-year history of working with athletes and military soldiers, female soldiers as well, with these types of issues. The benefits of sports, especially for girls, are well recognized. Organized athletics builds self-esteem, promotes physical conditioning, enhances skills, teaches the value of teamwork, and sets a foundation for lifelong physical activity. Athletic competition, however, as we've discussed already, can also lend itself to severe psychological and physical stress that is amplified in individuals already struggling with anxiety, depression, and perfectionism. And when the pressures of sport competition are added to cultural ideals that emphasize a certain body type, the risk increases for athletes to develop disordered eating. And Sarah went over some of the prevalence on this topic, but we have 42% of high school athletes that struggle with some form of disordered eating. 35% of female athletes struggle with some level of anorexia compared to 10% of male college athletes. Disordered eating affects so many, even at not a clinical level. So one very important point I'm going to make today, I'll say it again later in the presentation, most people, including athletes, will not meet full criteria for a diagnosable eating disorder because they don't always meet diagnostic criteria for every single point under that criteria. They're often described as subclinical, but that does not mean subimportant. So Sarah talked a little bit about describing the eating disorders, and this is not an overview of exhaustive symptoms, it's more hallmark symptoms. Many people, as Sarah also mentioned, think eating disorders look like anorexia on everybody, and lots of disordered eating does not. So in fact, anorexia is the most rare in many cases and the most deadly, as we've mentioned. But many eating disorders are hybrids of various symptoms. So as I said a minute ago, there's a category in the diagnostic manual that used to be called EDNOS, which is eating disorder not otherwise specified. Now it's a different acronym, other specified feeding or eating disorders, to encompass even more symptoms. But an example of this would be if, like atypical anorexia nervosa, an individual has restrictive eating behaviors and other symptoms of anorexia, however, they do not meet the low weight criteria. That would be an example of somebody that has a very severe problem, but a doctor would say, oh, well, you don't have a clinical eating disorder. So there's a general lack of understanding regarding the severity of OSPED and the importance of professional treatment with those grappling with this. A common misconception is that it's not severe, and some people believe that if you don't meet criteria, you don't need treatment. That is not true. Delaying treatment can result in developing co-occurring issue or worsening the severity of the current disorder. So that category was developed to encompass these individuals, which are most individuals. If you look at prevalence rate for OSPED compared to people who are diagnosed, it's much higher. The numbers are much higher. And so in community clinics, the majority of individuals from data are historically diagnosed with EDNOS or OSPED. This slide reflects what Sarah was talking about our biopsychosocial model of eating disorders. It takes all of these factors intercepting to create struggle. And these are all risk factors, but again, not an exhaustive list. And when these things come together, it produces the perfect storm and the perfect setting for issue to develop. And we have co-occurring depression, anxiety, trauma, substance use, as well as things like OCD, which was mentioned. So from that, I'm going to highlight a couple of big risk factors. The belief in the sport world that thinner and leaner athletes perform better is alive and well in sport. It has been since the inception of time, more so now as time has gone on. And it's also important to note that this pressure to be thin just doesn't exist just for athletes. This is a standard that exists in our society as a whole. It's just that the impact of our societal obsession with thinness and leanness trickles down and intensifies for athletes because of the attention that is paid to their bodies. So people are watching sports for a variety of reasons, but the body becomes part of that vision. And so we see more of this in what we call lean or aesthetic sports, sports that tend to emphasize appearance or weight. These are often individual sports versus team sports, judged sports. So when we talk about judged sports and scored sports, we're talking about gymnastics, bodybuilding, figure skating. This also includes running, diving, dance, track, and weight-dependent sports like wrestling is another good example, making weight to be in certain classes to perform. And typically in these sports, we see an excessive pressure to be lean, performing at all costs philosophy, having an academic scholarship that depends on sport performance, but dovetailing potentially with an appearance-based sport, and as well as the weight stigma. And just yesterday, this was an article in the media. Sport culture plays a significant role in the way an athlete views their overall worth. It goes deeper than body image and eating. It's identity. And it hits hard when people that young athletes respect and trust and admire are not being constructively critical, but are being more of a bully, if you will. And let me just say that bully is a big word, but it can be very, very subtle over time that this takes place. So the second big risk factor that we try to alter in big studies that we do on eating disorders, preventing eating disorders, is body image. We've done research in this area, and athletes actually often have two body images, one that's in the context of sport and one that's in the context of life. And sometimes they struggle with both of these or one of these. And sometimes these collide to create other issues. There's a pressure to perform in sport, but also look the part. And so this justifies, in some cases, underfueling or doing extra exercise than prescribed by the coach or the program. Social comparison is a killer. Athletes comparing themselves to other peers or athletes on social media or TV, or coaches pointing it out or family members pointing it out, this applies more pressure to achieve a certain look or even to the worth of the athlete. And weight stigma, even doctors. express weight stigma. And Sarah was talking about that earlier with how athletes look. So there's this battle of uniforms with female athletes. So there's been conversations as high level as the International Olympic Committee about this, why female athletes can't wear equally functional uniforms, but less revealing if they wish, such as gymnasts wearing unitards versus leotards, or volleyball players wearing shorts like the men instead of booty shorts, as they call them. It lends itself to a self-consciousness that can actually interrupt performance. So if female athletes are focused on their appearance and how their uniform is performing, it may impact performance and cause other issues, injuries. It gets dangerous if you're a gymnast in a leotard worried about how you look. It's been suggested in research that traits of good athletes and eating disorder characteristics can be similar. But when we refer to a good athlete, we are referring to a sport participant who not only performs well, but also possesses attributes that coaches value. And these are fair, like a kid that follows coach's instructions, selflessly committed to the team, and is satisfied with nothing less than perfection. In this vein, eating disorder behaviors may be encouraged in the name of performance, and these would be athletes that would comply. It's also worth mentioning that not every female athlete is driven to thinness intentionally. So this is very important because the root of eating disorders is not always body image and appearance. It can be that, and we have many athletes like this at the NCAA level that come into programs that unintentionally don't consume enough calories and end up in an energy deficit situation, which is a problem medically, but aren't experiencing some of the other mental health pieces. So keeping in mind that some athletes enter this space a different way is important. We had a patient one time that was very depressed and was sleeping most of the day, so she wasn't eating, but she really didn't have much struggle with body image. It was more of the depression that was the primary diagnosis. So it's important to kind of look at all the things. So keeping this in mind, we look at the REDS model. I put an article in the REDS model in the resource list because it is complicated. It can be its own whole webinar, but basically the female athlete triad in the past was defined and refers to the relationship between three interrelated components in female athletes. The relationship between energy availability, menstrual function, and bone health. And the IOC expert working group recently introduced a broader, more comprehensive term for this than the female athlete triad, because some of this affects males. So the relative energy deficiency in sport model points to the complexity involved. And it really refers to just the impaired physiological function, including but not limited to metabolic rate, menstrual function, bone health, immunity, protein synthesis, cardiovascular health, all produced by this energy deficiency. And the cause of this syndrome is relative to the balance between dietary intake and energy expenditure required for health and activities of daily living, and also sport. So basically not consuming enough calories, burning more calories, puts you at risk for metabolic consequences. And so this speaks to also long-term medical consequences in female athletes, like osteoporosis and fertility struggles, just to name a couple. And return to play for severe eating disorder diagnosed individuals with REDS is also based in part on outcomes with these issues, making sure that they're medically stable to go forward. Earlier, we said that lean sports were at a higher risk, and that is true. However, athletes living in larger bodies obviously can have eating disorders as well, as we said, and this is super important because doctors will overlook this. And frankly, if there was one take-home message, I would say that appearance just doesn't determine health. There was just a webinar yesterday on two women who were talking about their journeys with cancer and how people were praising them for their thin appearance. We have physical issues and psychological and behavioral with this, and these apply to everyone, no matter what shape or size their body is. Preoccupation with food and eating, preoccupation with shape and weight, depression, anxiety, irritability, all of those things refusing to eat certain categories of food, fear of fat, fear of certain foods, low self-esteem, loathing and guilt. All of these things dovetail. Given what I just went over about underfueling and performance behaviors, it's important to remember that performance and sport behaviors can be a slippery slope to an eating disorder. For example, very often we see in treatment that an athlete wanted to clean up their eating, maybe lose a couple of pounds and improve performance. And they may get praised for this behavior. They may find their way to some middle ground with this, which would be OSFED, where they're hanging between something that's considered a good performance behavior and an eating disorder. And it's from OSFED to full syndrome is not a very far space. So, you know, hitting this earlier than later is very important. It's worth mentioning, and I cannot stress the importance of mental health in totality enough, because it can be the difference in someone sort of dabbling in some behaviors and becoming a clinical case. All of these things are so interwoven. We saw mental health struggles heighten over COVID to an incredible degree. And I was grateful because when we started doing this work, nobody bought into the idea that athletes were struggling. And that said, we're seeing more intensity around this issue and a focus on suicide. This was an article just this week. And when we see an athlete struggling, we need to ask questions. We need to think about positive coping strategies and looking towards that. This is a whole other webinar, suicide prevention and how to deal with that. But one of the things that's most impactful on suicide risk that has been documented in many, many trials over the years that have tried all kinds of fancy things to impact suicide, basically is having a plan in place for someone who is feeling unsafe, feeling like something might happen. It's, if there's even a question, asking questions, asking if they're feeling down, asking if they might hurt themselves, and then mapping out a safety plan that they would intend to follow if they felt like they were in a dangerous situation. It's very simple, focused, straightforward thing to keep in mind versus we all get bogged down in clinical assessments and all of these things, but it is something that anybody can do. It's been shown, like I said, in the data that having a safety plan in place might be the difference between life and death. This is not talked about much, but for athletes that are already perfectionistic, already have an element of fear, another layer of anxiety and issues around control, feelings of out of control can lend itself to start trying to control something. One caveat is that sports with a fear factor tend to be in this category. And these sports are often not team sports, so people are up on a podium alone. It just comes with an added layer of struggle. And as a former gymnast, I can speak to this. You pretty much step up to the plate every time you're terrified to do a skill and you just do it anyway. But you need difficulty. And when you add difficulty, you add risk. And when you add risk, you add anxiety. And at some point, these individuals deal with a lot of anxiety. And so that is a big driving force for some of this. Throughout our years of work and in doing press for after the Olympics and people asking about Simone Biles walking off the floor and all of that, it has become very clear that this effect has been brewing over a long period of time. And we need a greater paradigm shift from a strictly performance-based approach to a whole athlete-based approach. And in this shift, we need to encourage other interests and identification early. And what I mean by that is we need athletes to have a more robust sense of self than just their athlete identity. Numerous athletes who have been interviewed have said and reported that if they had coaches and peers and family members who encourage them to follow their interests and develop themselves outside of sports and seek out things that they enjoy as a parallel to their sport, overall showed more resilience and were more well-rounded to deal with life challenges and transition later from sport into life. And so the idea is caring for our athletes beyond the field, helping them to develop, themselves as an athlete and a person in parallel. So what I meant by this paradigm shift to the whole athlete is philosophy really in most health paradigms, even in high performance, even the military, is this core of nutrition, fitness, and weight. Like people are very focused on these three things, but from a whole health model, we need to include sleep, mental health, and stress and resilience. Managing stress, positive coping are really key elements here. As part of a talk, I introduced a familiar philosophy, but it's often not the philosophy applied to our health, and we call this function over form. And the idea is that we can't judge health or performance by the appearance of a body, and that is foreign to many. And especially in our Western culture, where appearance is so valued in the context of people being very concerned about obesity, it's just a really huge conflict in how we look at health. So if you look at diverse athletes, like the ones on this slide, for example, each athlete is at the top of their game in performance, and yet they look very different. So we need to shift our focus from appearance to a focus on function. And even the military is doing this right now. They have made some serious changes to how they evaluate performance and readiness for the military. And they're doing more functional assessments of physical ability for the battlefield and not just looking at standards of weight. And that is a huge paradigm shift for that organization. Coaches can also contribute to a reduction of eating disorder risk. So I want to stress that because we've been talking a lot about groups, family, whether it's family, always, getting the blame, and that's not fair. A supportive environment which encourages athletes to make the best of themselves in and out of sport, and constructive criticism, productive criticism. General culture, contributes to this issue already. So our role as a support of the athlete is to be the turning point, to go against the pervasive messaging and support. And these are a few hard and fast tips. More can be found in the coach's toolkit from NITA, and I attached that as a resource. So I won't go through all of these. These are just a handful: de-emphasizing weight, encouraging athletes to focus on healthy ways to improve their performance, like working on strength and mental attitude, celebrate the talents and strengths, and instruct coaches and trainers to recognize signs. Awareness is important, and taking warning signs seriously. But like I said, there's very good information in that resource. We can also create a culture of prevention. So let me just say that treatment is good, but prevention is better. Eating disorders are hard to treat, and there are not enough skilled providers, and certainly less than specialized in athletes. And even with the best one-on-one therapy, a lot of people do not get better. Recovery rates aren't great for severe cases, honestly. To meet this need, there's a lot going on in prevention world. We also did a trial with NCAA and looking at healthy, positive coping skills and body image improvement and things like that. Just forming an environment in your sport world that is diversity positive, whether that's bodies, backgrounds, etc., is very important, because athletes can perform at any level in which they come to the table. So really holding an open environment and a very positive coping, stress management type of environment is very important. So some of the factors that we've looked at as basically resilience factors in the military also apply to our athletes, and these can be, some of these can be trained. So when we think of resilience, a lot of people think about a magical quality. Either you're resilient or you're not. That's not true. We can all gain skills that will make us cope better and are more resilient over time. And we know this from studies with kids. We know it from studies with the military, and now we're looking to apply this work to our female athletes. This is how the military defines resilience: rise in the face of adversity and strive to be healthy, both physically and mentally, no matter what the circumstances. And we know that working on our mood and anxiety and mindfulness is helpful. A couple comments on treatments. I saw this firsthand. I will say this: the longer someone has the issue, the longer it takes to get rid of. So heading it off at the pass is really key. It's your best bet. There are great tips on how to approach a struggling athlete in the resources that I sent. These webinars, you try to boil the whole ocean, but there's no time. So Sometimes it's early intervention with a coach or a family member that just sets the tone in a more positive way. They can head it off. Sometimes therapy is needed. Sometimes if actual inpatient treatment is needed or something like that, you're going to need a lot more medical stabilization and components like that. So to summarize, prevalence of eating disorders are significant in athletes. Subclinical is just as important. So our OSFED individuals are going to be more prevalent. So you're going to want to look for those. And they don't just occur in thin athletes. Eating disorders are caused by a perfect storm of various factors. Key risk factors are sport culture, which is something we can attempt to manage as either a family member, a coach, trainer, anybody that interacts with an athlete, and body image. Traits that make an individual a good athlete sometimes make them at higher risk for an eating disorder. REDS is a serious condition in female athletes and comes with medical complications, sometimes that span a lifetime if they aren't caught in time. The continuum of optimized athlete nutrition to an eating disorder is a slippery slope. So everybody loves the terms performance nutrition and precision nutrition now in the athlete world. But some of this really lends itself to more restrictive rules around eating. So keeping that in mind, athletes' overall mental health is compromised now more than ever, needs attention in general. So mood, all of that stuff. We need a paradigm shift in how we think about this to a whole person focus. Function over form is a key philosophy that we need to adopt to promote health, performance, and resilience for the long haul, longer life when the athlete is out of sport. And you can be the turning point. Anybody who touches an athlete can be a turning point for preventative sport culture, recognizing the signs, having a conversation, and possibly helping the athlete get treatment, and the earlier the better. And I have sent some links for resources. Down at the below, the specialty treatment for athletes, I know these two programs well. I can vouch for the treatment that goes on here. If you do a search, you will find very few programs in this country that are specialized for athletes. And these individuals are doing evidence-based treatment, cognitive behavioral therapy, mindfulness models, things like that. This is if you need to send an athlete to treatment, a very intensive model. Hopefully there are people in your area with outpatient providers, but it's tough to find. So at least use these folks as resources. And NITA has a call line. Also is very useful to get advice and get direction. And sometimes they'll have referral recommendations in your area. So check out those resources and the toolkit for coaches and trainers. And that's it. Thank you.
Thank you so much. I really appreciated your presentation. It is so important for us. And so now we're going to kick off our Q&A. We've got some questions in the chat, and I'm super excited. So please continue to put your questions in the chat. Also, feel free to come off mute and verbalize your question. So now to kick us off and get us started, I wanted to ask, if you see some of these signs and symptoms and you're concerned about a player, what are some ways to initiate that conversation?
Do you want me to take it?
Sure, I would love to hear from both of you, but Dr. Stewart, you can go first.
Well, let me just say, I think that most people are intimidated by having a conversation like that. So keep that in mind. It's a very human thing to be concerned, and we don't have to have the exact right tools. Initiation of a conversation is important. And I would say the main thing is compassion and approaching that in a way that if you were that individual, thinking about maybe what you would respond to, because sometimes it comes off as blame. Sometimes even if it's concern, can come off as a little aggressive or something like that. So those would be just off the top of my head. I will say that because there's a whole conversation about compassion as applied to these conversations and looking at it in an empathetic way in trying to reach the athlete from a compassionate place instead of, pure concern or pure blame, that kind of thing. Sometimes it can come across that way. But NIDA, I believe in that toolkit also has some lead in, like ways to lead into the conversation that are useful as well.
Thank you. Sarah, do you have any comments?
The only thing that I would say, and I'll share this in the chat as well, you may have actually shared this out already, but NIDA does have a really good toolkit on their website for schools and also for community that actually will probably talk a lot about the talking points that Tiffany and I spoke about today. But I think the most important thing that I would say is, like Tiffany said, is go at it with a caring, very, very caring attitude to where they feel very, very comfortable to talk to you about it, because it is a very hard discussion to even start.
Thank you so much for your answers. So the next question from our chat is there a guide for if you feel one of your athletes may have an eating disorder?
And so I would just say, if the department is aware of signs and symptoms and somebody tends to think that that might be happening, it's tough. It depends on the age of the athlete. So like, for example, with NCAA, they're at school, often they're away from home, they're treated as adults, they have their own health record that parents don't see, et cetera. And so it's a very different approach than, say, a middle school athlete or high school athlete still under parents. It's tough because there are many situations where athletes are being pressured by parents to be thinner, better, faster. The younger athletes are not sport diversified. They're specializing really early. So there's this whole creed about like what the athlete needs to be eating and doing at like 10 years old. It's crazy. So I think in that case, it's tough because knowing how to navigate with the athlete to figure out if something's really going on before approaching people that might have control over that situation, like parents, it's definitely a sticky one. I know that's not a solution, but I think if you have a good relationship with that athlete as a coach, you're able to talk to the athlete, asking questions, maybe keeping up with them a little more, if they come to practice every day, things like that, to really determine or get a feel for what's going on. And then maybe having a conversation with parents or other supportive coaches and trainers in figuring out how to move forward.
I agree with that as well. In Arkansas here, when we go into schools and we speak on this, we always will provide the toolkit, but also we will refer them on like to their school counselor. And then of course, if there's more treatment needed, then they will refer them out for treatment.
Thank you so much. The next question is Wrestle Like a Girl and USA Wrestling are building a female coaching course. Can you point us in the right direction for collaborators or resources that will help us develop a healthy wrestling culture? And the first thing I'll say about that is look out in your email. We're going to be sending out a whole bunch of the resources we've been talking about today. So look out in your email, and I'll pass it over to our presenters for any further recommendations or comments.
I'll just say that believe it or not, there are not tons of scientists working in this area. And so the treatment, we'd love it to follow the science, but many providers are still doing sort of older therapies and things like that. But there's a core group of us that are kind of bonded together doing this work, and we are available for conversations, consultations. I'm happy for you to contact me and ask questions or ask for resources. There's certainly people on the Olympic Committee and on NCAA and different groups that we work in that are tailored to certain sports that are like wrestling or gymnastics or things like that. So I'm happy to be a resource for this group. and there are other resources out there. We refer a lot to NITA because they have funded some of our studies. In fact, NITA is a very big partner in our work and work across the country. So they definitely, if they can't answer the question, they will also have resources to give as well. So I'll just throw that out there as a blanket sort of support, because this is an elite group. There are not many people working on this issue. And I can tell you, as an example, there was recently a fund put together to fund athlete research. And I'm making these numbers up, but they're close. It's about $150 million to study athletes and performance, whether that was mental, physical, or otherwise. Of that 150, 15 was set aside for female athlete research. So that's what we're working with. It's still not kind of as big a focus as it needs to be, but there's a core group working on it, and we're here. So
thank you. And I'm happy if you reach out to me, I'm happy to connect you with Dr. Stewart or any other resource that you might need. So thank you so much. And Sarah, did you have any additional comments?
I do not. I honestly can't speak to that. But I would be happy, to do research on that, but I can't speak to that specifically.
Okay, thank you so much.
The only other comment I would make is on my prevention slide, I had a logo for a prevention program that we deployed in an NIH trial. And we deployed it in 4 universities and it worked well. So we now give that program, that manual, to other universities who want to use it. There is a younger version of that being developed right now. And it targets body image and other prevention factors for female athletes. So that will be available as well.
Thank you so much. That's awesome. So our next question is, what is a good way to approach middle school and high school coaches so that they can be aware of this issue?
That is a great question. And here's why. It's one of the hardest things that we have worked on as professionals from the beginning of all this. In fact, when we started deploying trials in schools, which is mainly college, I will add, they said, don't even try to talk to coaches because they're part of the environment and they don't want to change and all this stuff. And so our initial goals with some of this behavior change was with athletes directly or with other groups. But because coaches are such agents of change, they need to be part of this conversation. Sometimes it is difficult to approach a coach when you're a parent or someone from the community that's concerned maybe about things that they're doing with their athletes. I hope that ultimately we will have a curriculum that coaches can participate in if they desire. But again, NITA has really great resources right now for this. So if you feel like your coaches would benefit from somebody coming in and giving a talk, there are people that would do that. I think hearing signs and symptoms to watch for and also knowing how to not make it worse in the environment is very important. But who they need to hear that from sometimes is an interesting choice, depending on what sport it is. And if appearance is a valued piece of performance, that can make it harder. But check the NITA toolkit because that is still a good resource for that.
And again, please reach out to us. We would love to be a resource and to help in any way possible. And Sarah, did you have any comments on the best way to approach coaches?
I agree with her on that. I think we in Arkansas, we go out in, like I said, into the schools. And so we will educate the teachers and coaches on eating disorders. We're very, very close to what I presented today. Just kind of the warning signs and treatment and ways to help and things not to do. And so that's kind of our approach here.
Thank you so much. And someone mentioned that Tucker Center at U, Minnesota is working on a course related to healthy body image in female athletes. So keep an eye out for more on that. And thank you so much for that. Please, I would be very interested in that. Whenever that comes out, please reach out to me and share. And I'd be happy to share that out with folks. And of course, Thank you so much to our presenters. People are saying thank you and what a great presentation this was in the comments. So we really, really appreciate your time today. So thank you so much for that. And everyone, please, this is the first of 4 webinars on health and wellness in girls sports. Please join us for the next one. Please register for the next one if you haven't already. It is going to be on April the 4th. So April 4th at 1 p.m. Central Time, and that'll be in your email as well. And I'm going to put the link to register here in the chat. So please register for our next webinar series. We're really excited about it. And next slide, please. And with that being said, thank you everybody for being here today. Please take our evaluation. You can use the QR code here, or you can use the link which I put in the chat. So with that being said, thank you all very much and have a great day.